So today is the third session of my lectures, and we'll cover a little bit, or we continue a bit where we left off last time, and talk about strain and a little bit about torsion also, as you will see. Okay, so I mentioned this last time also. So when we're going to look at cardiac deformation, we want to express this as a value, and for that we do measure strain. And so strain is defined as the change in the dimensions of an object with regards to an initial state. So that means that it's expressed percentage, but one thing which is also relevant then is that there has to be an initial state for the strain measurements. You will see that that is actually still a little bit of a controversy in cardiology, on cardiac imaging, because at the one hand, well, there's actually three different things that play a role when you want to look at what do you want to take as reference. Physiologically, the cardiac cycle is starting with the activation of the sinus node, which is actually in the so that's the beginning of the atrial contraction. So that's actually your P wave. So, but in clinical reality, we mostly concentrate on the ventricles in order to look at strain. And so the QRS complex there is the thing that is relevant. And when we look at the ventricle, it's actually the onset of the activation of the ventricle that we would think is the most relevant physiologically. So that would be the onset of the QRS complex in the ECG. But to detect this automatically on ECGs is not an easy task because of the kind of the heterogeneities in the morphology. And so very often companies are using the R wave, so the peak of the R wave on the ECG as a reference, as kind of indication of this is the onset of the cycle. But the peak of R wave physiologically has not much of a meaning. It's just the point where most of the electrical activity is taking place. But with regard to the mechanics and physiology, that doesn't have a real meaning. But the thing is, it's technically much easier to detect. And so you will actually see that in the guidelines for deformation imaging, because there is like a committee that has been working on trying to standardize deformation imaging, because all of the companies now, whether it's based on ultrasound or MRI or things like that, use different algorithms. We'll come back to that in a minute. And so they get different values. So there is some kind of initiative in order to try to standardize this. And that committee, under the influence of the industry, has now proposed to use the peak of R wave as the start. I don't particularly like that because, as I said, there's no physiological meaning, but it's something to take into account. Of course, you can adapt it with your interpretation, but still the most important to know is keep in mind that strain has like a reference value from which you calculate. Of course, since the cardiac cycle is something dynamic, deformation is taking place in a dynamic way. We will see also that this temporal evolution of the strain can be different, because in the end, the strain is induced by a balance of the force generation by the myocardium with the force or the pressure that has to be overcome. We'll come back to that also in some of the next classes, how this is relevant. But that means that there's a potential temporal course which can change within pathology. Now, one thing is to look at the full temporal course. The other thing is also to look just in some ways at the instantaneous velocity of the deformation. So the instantaneous speed at which the tissue is deforming, and that is obviously the strain rate. As I said before, so you see in this kind of clip below here, you see two pieces of myocardium, which in the end, after the contraction period, have deformed the same. So the value of the strain in the end, so the maximal strain or the end systolic strain, as it's very often being used, is exactly the same, but the strain rate at which this is taking place is obviously different. And as I mentioned also last time, an intuitive way to look at strain and strain rate although they're obviously mathematically connected, because one is like the temporal integral of the other. So what you can say is that the strain, so the amount of deformation when you look at it at the level of a ventricle, will somehow correspond to the amount of change in the volume of the ventricle, and so would be related to the stroke volume every time. So with a certain ventricle, the more strain you will have, the more stroke volume you will be able to generate. That is the final strain, so the maximal strain, let's say it that way. Then when we look at the strain rate, you will see that the faster you can deform, likely the more force you're using in order to do this. And so that is partially related to what we call the contractility and the myocardial force development. But we'll come back to that later on. Now, as I said also in one of the previous sessions, is in order to understand cardiac deformation and strain patterns, and especially regional strain patterns, what we really have to do is we have to look at the interaction of different segments and how this is actually integrated in a whole ventricle. And just to show you here an example of what you have to keep in mind when you're interpreting this. So let's say here, this upper part would be normal deformation. So as we said, it's kind of stylized. So you have two pieces of myocardium. Say that this would be a septal wall, for example, and you have here the apex. And as I mentioned before, the apex is stationary within the thorax in normal cases. And so what you have is, because of the deformation of all the different segments, what you will have is that the valve plane will actually kind of be dragged towards the apex. Now, what you have is then when you, for example, have ischemic heart disease and you have infarcts. So what you could have is, for example, this one would have like a large basal infarct, so that, for example, the half of this wall would be infarcted. And when it's infarcted, it can obviously not deform. So what you will have is that you see that locally in that infarction area, you will have no deformation, so no strain, but still you will see that there's motion, of course, because it's being dragged by the apical segment, which is contracting. This is actually what we call tethering. So you not only should look at motion of segments, obviously, but you have to look at the local deformation. Now, if that infarct would now be localized apically instead of basally, what you will see is that actually, because the apex is not moving, we see that the apex is, of course, not moving neither. But what is interesting to see is as I also mentioned at some point, so by the fact that we know that the apex is stationary within the thorax, and we have then the valve plane, which in the longitudinal direction is being dragged to the apex. So just looking at the displacement of this valve plane gives you something, or gives you like a rough idea on the overall deformation of the valve. And you see that here also is when we look at the displacement of this valve plane. So you see in the normal case, you see that there's much more displacement than in this abnormal case. But you see that the displacement will be the same independent of where that infarct is located. So you see that this gives you information about the wall in itself, but it doesn't tell you which part of the wall would have a problem. Now, when we are looking at, unfortunately, sorry, let me see, I need to get this movie to run. Okay, so when you look standardly at how clinicians are making reports of echocardiographic images or even MRI images in order to visually assess the deformation in segments, they kind of have different categories. So they would call it either normokinetic, so that means that the kinetics is normal. It could be hypokinetic, which means that the deformation in the end is less. It could be akinetic, which is like here, so which is then it's not deforming at all, or it could be dyskinetic, which means that instead of shortening, it's actually lengthening during the cardiac cycle. Now, why do you get this lengthening, and what is the difference between an akinetic segment and a dyskinetic segment? Well, one of the things that could be the case is that, for example, if you have an akinetic segment, so what you have is, in this case, this apex is akinetic. And so what you have is that when you have the contraction, what you see is that the basal segment would be moving towards the apex because it can contract. But keep in mind that actually when this basal segment is deforming, it actually will develop a force on this apical segment also, because as we said before, it's connected. And so you have the pressure inside the ventricle, and then you have this deformation of the base. If this apical segment is like an infarct, or if the pressure inside the ventricle is like normal, what you will see is that this force development by the basal segment will form the basal segment, but will not interact too much with this apical segment. But say now that the same patient with the same infarct would develop hypertension. So that means that the blood pressure in the periphery is rising. So that means that, of course, the ventricular pressure also has to increase. So that means that the force development by the myocardium has to increase in order to be able to develop this pressure. What you now see is that, of course, because of this increased force development of this basal segment, what can happen is that this force will be so big that it actually starts to stretch this apical segment. And that's where you get dyskinesia. So you see already that looking at the deformation and interpreting this deformation has to do with, is there still some contractile force in that segment? Has to do with the elasticity of that segment, because if this is like a fully infarcted segment and became full fibrosis, like a big scar, of course, it's very stiff. If it's not a big scar, then you will see that the interaction of the different segments with the pressure that needs to be developed in the ventricle will actually determine what the kind of deformation will be of this certain segment. So that means that when you measure a local strain pattern, you can never interpret this in itself. You always have to interpret it in relation with what's happening in the surroundings, and also what's happening with the loading, as we say, of the ventricle. So what's happening with the pressure. Now, I'll just quickly come back to this, but or mention this. We come back to that at another thing. It's like what you see is in cardiology, in cardiac imaging, you have this kind of holy grail where people try to develop parameters in order to quantify function, which is what they say load independent. So that would be independent of the blood pressure that is developed within the ventricle. And so you have some which are very load dependent, and sometimes you see publications that say like, oh, we finally found a load independent parameter. Now, this is kind of rubbish. That doesn't exist in cardiology. Everything you see will be dependent on the pressure inside. Now, partially depending on when you measure in the cardiac cycle, it might be that you have a different pressure when we look at the dynamics. So there might be some more or less load dependency of different parameters, but nothing is totally load independent. So having an idea of the load when you look at these parameters is actually quite important. So that means that with every imaging study that you try to interpret, you actually need to have at least an estimate of the blood pressure in order to try to interpret this. Okay, so how do we measure deformation? When we do it with ultrasound, there is two main ways in order to do it. And one is based actually on velocities, but actually all of it is actually based on the fact that what you try to do is you try to follow 2 points, 2 spatial positions in as a function of time. And so what you see is like, if you have 2 points in these and during the cardiac cycle, they move with the same velocity in one direction or the other, then you know that in between there's no deformation. If one of these points is moving with a faster velocity than the other one, then you know that there is deformation. So actually, the spatial gradient of the instantaneous velocity is actually related to the deformation. And actually, you can prove it's related to the strain rate, to the rate of deformation. And you can actually see this. So if you, for example, would use tissue Doppler imaging, so which is really a Doppler methodology that measures the velocity of a piece of tissue within the myocardium. And so what you can see is if you take 2 points, so you have 2 curves, velocity of 2 points, then you see that this difference between these two curves is actually related to, at that moment, the instantaneous rate of deformation. Okay. Now, so then the way to calculate it is obviously, so if you would base it on tissue Doppler, which is one of the methodologies, which is a methodology which has an advantage in the sense that tissue Doppler can be acquired at very high frame rates. So you can do it with very, very high temporal resolution. And when you look at deformation imaging in cardiology, it actually started with this type of tissue Doppler based approach. Currently, it's not very popular to do it this way. It's a little bit of a pity, but it's partially also, again, pushed by the industry. I'll come back to that later, why that will be. But this is one of the techniques, let's say it that way. And so what you do is you measure the velocity of 2 points, you measure the distance between them, you look at the spatial derivative of it, and then you get actually, as a function of time, you get this instantaneous strain rate. And so this is a typical strain rate curve that you would extract. So what you will see is, so this is the indication of the cardiac cycle. So what you will see is during systole, when we look in this case, so this is an apical view of the left ventricle. So this is the apex. Here you have the base, so the valve plane. And you're actually looking at this wall, in this case, a septal wall, and you're looking at the longitudinal deformation. Right? So you're looking at, when you take the spatial gradient in this direction, you're looking at the longitudinal deformation. And so what you will see is that during the contraction, so during the ejection phase, you see that the tissue will shorten. And so so just by definition, so what you do is, what we say is that if an object is lengthening in dimension, we say that the strain is positive, it's shortening, the strain is negative. So what you will see is that also the strain rate, so in the beginning during ejection, the strain rate will be negative. And then at the end of ejection, it becomes 0 again. And then you see that you start to get lengthening, and you get lengthening in 2 phases. So you have first the early lengthening during the early filling, and then you have the lengthening during atrial contraction. So this is early and late filling. We come back to that filling in one of the other sections, but you know that during filling there's 2 phases. During ejection there's 1, and the strain is in the longitudinal direction negative, strain rate and strain we will see is negative, and during the filling it becomes positive. Now, if we now take the temporal integral of this deformation, then of course, of this rate of deformation, then of course we get the deformation, and then we get the strain curves. So now here it's looking in the other direction. So now this is a parasternal view. So we're looking here. So this is the wall. So this is in this case the lateral wall. Here you have the septal wall. We're now looking at the deformation in this direction. We always, with tissue Doppler based, we always only measure the deformation in the direction of the ultrasound beam, so which comes from the transducer and goes in this direction. So we're looking here now at the thickening of the myocardium. So as I told you before, we have radial thickening because of the fact that we have longitudinal shortening, we have circumferential shortening, and so because of conservation of volume, we need to have radial thickening, and that's what you see here. So in the radial direction, strain rate will be positive during the ejection and negative during the filling. And if we look at the integral, so you see that deformation is increasing during the ejection phase, and then decreases fast during the early filling, and then decreases more during the late filling. So these are these typical traces that we get. Now, the type of deformation measurement that is currently mainly used in cardiology, then based on ultrasound, is actually based on speckle tracking, say. And so what you do is when you look at an ultrasound image, so you very typically see the speckle pattern. And that's actually because of the interference of scatter reflections. So these speckles, at least instantaneously, are really linked to the local distribution of scatters and so to the local tissue. So if we look at the change of the speckles position over time, at least over a short period of time, these speckles really move with the myocardium. And so if we identify these speckles and we then track them during over time, what we can see is we can really measure the change in position. We can measure the local velocity, and again, if we look at the position of 2 points and we look at the difference, we can then measure the deformation. Now, this is based on 2D grayscale imaging. So that means that the temporal resolution here is actually determined by the frame rate. Because what we do is we look at the displacement of these speckles and in consecutive frames. Now, frame rate in ultrasound, although it's a kind of a real-time technique, is like currently we work mostly around 50, 60, up to 80, 100 frames per second. But 100 frames per second is already quite a lot. So at least in adult cardiology. While when we do, for example, tissue Doppler imaging, because of the fact that it works in a different way, we actually have frame rates or data rates of more than 200 frames per second. And even we can go even more. So the disadvantage of grayscale-based techniques is that it's actually limited in temporal resolution, which can be important for some instances. So there will be, we will see later on that there's some fast events in the cardiac cycle where actually we need a frame rate which is much higher than the 50 frames per second regularly. Now, one rule of thumb that you can use in strain imaging is that you try to have a frame rate which is at least as close as possible to the heart rate. So if you have a patient with a heart rate of 60, then a frame rate of 60 is reasonable, let's say it that way. That means, for example, when we look at pediatric applications, where patients, where young kids have heart rates of 120 or even more, we actually need higher frame rates. Now, we mostly can do higher frame rates in these also because, of course, they have smaller hearts, so our depth of ultrasound imaging is less. But this is something always to keep in mind, that you go as close as possible to this 1:1 ratio to be as safe as possible. Now, one other thing is also so what they say is that the Doppler technique intrinsically is what they say is angle dependent, because you can only measure the velocity with Doppler in the direction of the beam. So you cannot measure the components which are perpendicular to this. So that means that you like to look at deformation and motion, which is in the direction of the beam. Now, mostly this is not too bad, because in apical imaging, we can actually align the wall that we're looking at with the beam. But what I then say is another advantage in brackets of speckle tracking would be that it's angle independent. But keep in mind, angle independence in ultrasound, in cardiac ultrasound, where you have sector images, does not exist. Because by the fact that you're using sector imaging, that means that the deeper you go, you actually have a different lateral resolution than wherever, and always the resolution on the scan line is much bigger than the lateral resolution at any position. So that means that there always is a angle dependency, and it's always much easier to follow speckles in the direction of the beam than rather perpendicular to the beam. Now, but it's of course much less of a problem as compared to Doppler. Now, the other thing is also speckle tracking. One of the things is also that, of course, speckles, as I said before, in a short period of time, they are actually stable. But when we look at a couple of frames later, what we see is that patterns are actually changing. So speckles appear and disappear, and we have to each time track other ones. So that means that when we do deformation imaging or tracking of this, we need quite a lot of regularization in order to really nicely follow these speckles during the cardiac cycle. And regularization, of course, means smoothing in reality. So what you see is that speckle tracking is highly reproducible, especially as compared to current implementations of tissue Doppler, partially because of the fact that there's actually quite a lot of regularization. But of course, that means that there's a lot of smoothing. So you really have to take care whether what you're looking at, whether that's not smoothed out. And I'll come back to that later on. Well, actually, here is an example. So although this is a relatively old example, and I think things are a little bit improved nowadays, especially also with standardization of deformation imaging. But what you will see is, so here's an example of a study that was looking at, in this case, this is a patient with an infarct, where you see that, so in infarct regions, you see you have very abnormal strain. You see here, this is more or less a normal strain pattern, but here you see very, very abnormal reduced strain patterns. And this is actually one of the original kind of validation studies where they actually used an animal experiments where they induced certain amounts of transmurality of infarct. So when you have an infarct in a wall, and we come back to that later on also, but what is important to know is that when you would have a problem with the coronary arteries, because of the fact that they are actually at the epicardium, at the outside of the heart, what you will see that an infarct is always starting at the endocardium. So the most distal part from the epicardial coronary arteries. And the longer you have an occlusion of a coronary artery, what you will see is that the more transmural, so the bigger throughout the wall this infarct becomes. And so that means that you have patients, and in this case, so it's an animal model with different degrees of transmurality of infarction. And what you already can imagine is that, of course, the more infarction you have, the less deformation you will have in that segment. And one of the things also that you know physiologically, as I partially showed in the cartoon, is like if you have a full transmural infarction, so that means that you have no viable contracting tissue anymore within the whole wall, then by definition, your deformation has to be zero. You can still have some interaction between segments and then mainly get stretching, but you will have very, very, very little kind of shortening in that segment. Well, when we look at this experiment, what you see is like in the almost transmural infarctions, what you see is that although obviously you have reduced strains, but what you see is that there's still quite a lot of deformation. Well, this is a transmural infarction. This is impossible. This cannot be. Physiologically, this is impossible. Now, the reason for this is twofold. One is that when we look at how strain is reported, so what we have here is, so we have a typical four-chamber view. And what we do is we actually divide this four-chamber in segments. Mostly what we do is every view, we divide it in 6 segments. So 3 segments in the septum, 3 segments in the lateral wall. And these are standardized segments. And if we use a computer in order to do it, this is really 1/3 of the wall each time. But of course, you can already imagine when we have an infarct in a patient that is related to an occlusion somewhere in a coronary artery, these infarcts are obviously not related to the segments that we are defining kind of artificially in some ways in this image. So that means that the infarct region can be smaller than the standard segment, can be bigger than the standard segment, can be overlapping between 2 different segments. So that means that when we look at these curves, at these measurements, there actually can be very often a mixture, a smoothing of normal tissue versus abnormal tissue. And the other thing is also that now, depending on the spatial smoothing, so the spatial regularization that we're using for the strain calculation, again, also, it might be that we have pure infarct region or boundary region or combined with normal region. And so that makes that actually the absolute measurement sometimes is not really representing the underlying tissue. How can you solve this? Well, one of the things is, of course, to reduce the spatial smoothing and to very much reduce the size of the segments you're looking at. The disadvantage of this is, of course, it becomes much more noisy and you have many more strain curves that you have to look at. So, and people, especially clinicians, they like smooth curves and kind of clean, very reproducible measurements. So they like to have the smooth. But keep in mind, depending on the underlying pathophysiology that you want to detect, this might be problematic, yes or no. So this is really important to keep in mind when you interpret real clinical strain traces. Okay, so I showed you this last time also already. So what we have is, because of the fact that we have this very typical fiber orientation, and we look at it clinically. So the components that we're looking at is, at one hand, so the longitudinal shortening, so base going to the apex, then the circumferential shortening, and then the radial thickening. So these are like the normal strain components. Now, what I also told you before is that because of the fact that when you look at your fiber orientation, or at least the orientation of the myocytes within the wall, what we will see is that actually at the epicardium, the myocytes are oblique in some way. At the endocardium, they are oblique, but in the other direction. Now, what we now see during the contraction is that, of course, if the epicardial fibers contract, they will actually rotate the base from the apex in one direction. Now, the endocardial fibers are oblique in the different direction, and they will also cause rotation, but of course, counter rotation to what the epicardium does. What we will see is, because of the fact that we have clean fibers and brackets at the epicardium, while the endocardium also has this trabecular pattern, plus the fact that the epicardial fibers are further away from the center of rotation of the myocardium, what we will see is that actually during the cardiac cycle, it's actually the epicardial layer which is dominant, and that induces, as you can see here, that induces some rotation. And so we see here, can I get this moving? No. I go back. Okay, so here you see it moving. So you see here on these MRI tagged images where these lines are really connected to the tissue, what you see is that the base is rotating in one direction, and you see that the apex is rotating in the other direction. And so you can actually measure this either with MRI, or you can also measure this with speckle tracking, of course, if you look at short axes and you see how they rotate over time. So when we look at then the complex deformation of a certain segment, so if we start with some kind of tetrahedric segment, or whatever you can call it, you see that this deformation actually becomes very complex. So we have the shortening and the thickening, and then we have this kind of skewing. So we have all these different components. Now, the question is, what are the important ones? Is it the shearing? Is it the deformation, longitudinal, circumferential? I mean, there's still a lot of debate about it. One of the things that we will see, and we come back to that later on also, is that actually the longitudinal one is actually one of the most interesting ones, because the longitudinal shortening, as we said before, is predominantly caused by the epi and the endocardial fibers. And because of the fact that most of the cardiac diseases is actually affecting the endocardial tissue earlier compared to all the rest, what we see is that this longitudinal component is actually changing much earlier compared to the rest. Now, with regard to the rotation and torsion, so people have been investigating this also, because we can measure it. And there are some interesting things that you can look at. So here you see actually this rotation curves of base and apex during the cardiac cycle. And now one of the interesting things that you also see is, so I told you the endo and epicardial fibers are in different directions, so are oblique in different directions. So that means that they will do rotation in different directions. And one of the other things that I also told you already in one of the previous lectures is that when we look at the activation system, so the conduction system that does the electrical activation of the myocardium, what we will see is that is located endocardially. And in humans, the connection of the conduction system with the tissue is actually endocardial. We don't have fibers, Purkinje fibers, so these electrical wires, which go within the myocardium. There's some animal species like cows and sheep and so on that do have this, but humans don't. So that means that your endocardial myocytes are activated before the epicardium, because as we said before, Purkinje activation is fast, and then the electrical activation has to travel through the wall from endo to epi, and that is much slower. So in reality, your endocardial fibers will contract earlier compared to your epicardial fibers. And since they're oblique in a different direction, so what you see is that actually initially you get rotation, which is kind of caused by the endocardial fibers. And then only when the epicardial fibers are starting to take over, you start to see that you get the rotation in the different direction. And you get the kind of counter rotation back during the filling. Now, one of the things that you see also, and you can see that also in this plot, is so what you see is that actually the rotation during the ejection phase is relatively linear. So it happens at a similar velocity. Yeah? So that means that during the ejection, you get this rotation, which is continuously, which is gradually, and which is more or less linear. Now, what you see is at the filling, what you actually see is that while the rotation during contraction is smooth linear, you see this very rapid untwisting, as they say, and then you start to see that you get further relaxation. So you see that this kind of untwisting or unrotation, whatever you call it, is much faster compared to the systolic one. So that is what happens in the early diastolic phases. You see that also in this kind of plot, where you see a plot of torsion versus displacement, more or less linear during systole, and then rapid in early diastole, and then going down. What is causing this is actually totally unclear. We don't know yet. I mean, I don't know. There might be some hypothesis, but so this is something which might be interesting, but I don't think there's a good answer for it. Now the question is, can we do something with this measurement of rotation? Because one of the things that you will see is that, of course, the better your function, the better your rotation will be. And also, since this rotation is there, what you see is that some people in papers and conferences, they have said like, okay, we have our longitudinal circumferential radiant component, and then we have independently these rotation, twisting, or torsion components, depending on whether you do the rotation, or you measure the difference in degree, or you normalize that by the distance of where you measure it. So they say like this has also information, and we can use this measurement as an independent measure of cardiac function. Now, I'm not a great believer in that because of the fact that through, of course, the fiber orientation, these components are linked. So they are geometrically linked in some ways. So that means that actually the more longitudinal shortening you will have, the more torsion you will have. So in some ways, these are related. Now, the other thing is also, how is this changing with disease? Because what you want to have is that you do a measurement which gives you changes, where you can measure changes that help you in order to look at abnormalities in some ways. And for that is, if we just even look at how is changing with age, one of the things that we see is that actually the apical and basal rotation, what you see is that with aging, you see that this is actually changing. And so your torsion, so your degrees per centimeter of torsion that you get, you will see that torsion is actually increasing with age. And the reason why this is actually, again, related to your fiber orientation, because what I told you before is like you have your epicardial fibers in one direction, your endocardial fibers in the other direction. As I said, the epicardial fibers are dominant, but the endocardial fibers, they actually are counteracting. So the endocardial fibers make that the rotation is actually less than what it would be done only by the epicardial fibers. Now, as I told you before, it's like with many cardiac diseases, and actually also when you age, so when you become older, what happens is that mostly your vessels, your peripheral vessels, become a bit stiffer. So that means that your blood pressure is rising gradually with your age. So that means that actually also your endocardium, and also, of course, you get changes in the coronaries and so on. So that means that you actually, with age, you're losing more and more of your endocardial function, because of pressure-related issues and because of perfusion-related issues. And you can already imagine that, of course, if you lose your endocardial fibers that are counteracting this rotation, that means that you get increased rotation, because the epicardium is starting to dominate. So you see here an increase in torsion because of the fact that you have your natural decrease in endocardial function. This is counterintuitive if you would say that your torsion is related to function, because what you will see is that with age, and actually also with pressure loading, so for example, with aortic stenosis or hypertension, you will see that your rotation increases. But if you have like a really big infarct, then it decreases again. So actually using this value of rotation in order to make clinical decisions is very tricky because of the fact that it's actually quite complex in order to interpret this. Similarly, what people have been then looking at is using this untwisting, so this fast decrease in the diastolic period in order to link that to systolic function. And we can come back to that when we talk about diastolic dysfunction, but actually that correlates, so this untwisting rate correlates with what you call tau, and tau is actually the time constant of the decrease of the pressure within the ventricle, which tells you something about how good or how fast the relaxation is taking place. So theoretically, it can tell you something about this. Again, keep in mind that it is related, of course, the amount of untwisting is related to the amount of initial twisting that you have. It's also related to the elasticity, because it's likely some kind of elastic recoil of the tissue that is doing this. And torsion is not always too easy to measure. So that means that in reality, although there is some literature on this, it's not a clinical parameter that's being used. But it's important to keep that in mind. Now, something which is actually very, very interesting and also tells you that the torsion is related to the amount of deformation taking place together with fiber orientation is a very interesting study that has been done by the group of the University of Maastricht. And what they did is they actually looked at the fiber orientation in patients with situs inversus totalis. And that means that these are patients where the inner organs and the heart, where everything is mirrored, but perfectly mirrored. And these people, they are actually totally healthy. There is no kind of big problem with situs inversus totalis as long as it's fully mirrored. And so what you see there is that, so during development, for some genetic reason or whatever reason, you will see that the heart is now at the right side and pointing to the right. And if we look at the fiber orientation, what we now see is that actually this is not a mirror. What we see is that the fiber orientation is actually different and very different in these people. Because what you have to keep in mind is like this fiber orientation, so the orientation of how the fibers are there, you have to look at it how it embryologically develops. So first of all, the situs is likely determined genetically very, very early on, because it has to be really in the very early stage of development that it's decided that everything would be mirrored. But then when we look at the development of the myocardium, what we see is that, of course, is like gradually taking place and is also going from the spongy myocardium in the beginning towards the more compacted myocardium later on, as I said before. And so layers of myocyte are being added during the development. So the fiber orientation is actually partially determined by the dynamic forces, both mechanical forces and hydrodynamic forces that are taking place during the development. And of course, while in situs inversus, the initial and the genetics are mirrored, the hydrodynamic forces are of course not mirrored, because it's still the blood going through the ventricle in some ways. And so you will see that this combination, actually what you get is that you get a different solution of this optimization problem, because in the end, engineering-wise, it's an optimization to have an optimal fiber orientation, giving the circumstances in order to, with the lowest energy, get most of the deformation. And so, as I said before, what you have is in your control hearts, what you have is you have a change in the angle from epi to endocardium, but that is very, very homogeneous in the base and the apex. And what you see is that in the situs inversus totalis actually happens is that you actually have a change where in the base and the apex, you have this difference. So you also have a smooth fiber orientation, and this fiber orientation is also an optimal solution in order to get with the lowest energy available, but with a different kind of starting condition, which is because of this. And what you will see is that when you have this type of fiber orientation, which is perfectly fine for normal cardiac function, what you see is that you actually have much, much less torsion because of the fact that you don't have this kind of nice kind of direction anymore. So that tells me again that this torsion component is not crucial for cardiac function, but it's actually the mechanical result in some ways from the contraction, the longitudinal contraction of the myocytes together with this fiber orientation. And one of the things that is also interesting to see is that this torsion actually depends also on the total geometry of the ventricle, because what it does is depends, as I said before, it depends on the angle of the myocytes with regard to the long axis, because you have the rotation that you measure with regard to this kind of central long axis. And what you see is, for example, this is now an example of actually during surgery. So what you have is, what I told you before, is the whole heart is actually packed within the pericardium, the stiff pericardial sac. And the pericardium makes that the shape, the outside shape of your heart is not changing. And so during surgery, what happens is that in order to do, in this case, this is an example of coronary artery bypass surgery, what you need to do is the surgeon needs to cut open the pericardium. And what you have is, if you change the pericardial constraint, what happens is that actually the heart bulges because of the pressure inside. You know, as I said before, a balloon is as spherical as possible. So if you take away the constraint of the pericardium, you see that the heart kind of bulges a little bit. And what you see, for example, is when you look at the right ventricle now, in this case, as a measurement, what you see is that because of this bulging, the angle at which the right ventricle intersects with the left ventricle is increasing because of this bulging. And what you now see is that because of this geometry change, first of all, what you see is that actually the longitudinal deformation is changing. And so the only thing you do is you open the pericardium. You're not changing the contractility of the myocardium. So you're not changing the force development. You're not changing the pressure inside. You only change the geometry. And you see that because of this change of the geometry, you see that the deformation is taking place differently. And what you actually also see is that, for example, the twisting is reducing. So, and as I said before, longitudinal deformation and twisting are very closely related. So you will see that again, these measurements not only depends on the segment itself, it depends on the interaction of the different segments, it depends on the pressure inside, but it also depends on the whole geometry of the heart, because you always have to look at how are myocytes oriented with regard to the endocardium in order to kind of transfer their force into pressure due to the deformation. Okay. I think that's enough for today. Any questions? A lot of information. So I told you before, these things are now on YouTube, so you can re-watch it whenever you want. And if there are parts of it that you want to have repetition or you want to have more details or things like that, just send me an email and let me know.
Just a very fast question. Thank you a lot. I think we are all learning a lot. It's very, very nice. This last part, when you say that the pericardium is open in a surgery, is it closed again, or?
Yeah, that's still a big discussion. Mostly not, because it's not so easy to nicely close it again, because of the fact that, of course, you have to then squeeze the heart in again. So, but there is a little bit of discussion amongst surgeons whether you should close it or not. The thing is, in order to have the most efficient working heart afterwards, you should close it because it's it's an important part of it. But in reality, very often it's not.
Mm-hmm. So these patients tend to be more like followed up quite closely then.
Yeah, but mostly this little bit of contribution of this opening of the pericardium doesn't make that much of a difference, because as I said before, the fact that you open the heart means that you're going to do some serious surgery, and the effect of that surgery will be much more than the little bit of efficiency that you lose because of this pericardial sac. So
fair point, of course.